coming today. We know how busy you are. And we also know how complicated this new law is. So we appreciate you taking the time out of your busy schedule and coming today. There are probably a little over 500 people that registered, which is the biggest group we've ever had. We sent out an email blast immediately after the Supreme Court made their decision, announcing that we were going to have this seminar. And within 90 minutes, we had 300 people that had already signed up. We've enjoyed the dialogue back and forth. As is true with any law, it's ironic that the Congress, and this is Republicans and Democrats, will pass something and we'll sit up there and then we're forced to deal with it down here. And this is probably, if it's not the most complicated law, not just in the benefits area, I think it's the most complicated law I've ever read. And it's the most, in my opinion, again, one of the most important laws. And we could spend the next 3 weeks trying to define how we got here, but that's really irrelevant. What we want to stress today is, where do we go from here? Or as the title says, now what? And the answer to that question is going to vary from employer to employer. It really is. This law is a game changer. So we're appreciative that you're here. I think you're going to get a lot out of the next 3 hours. And we have condensed a lot of information into the 3-hour spots. So historically what we've said is, if you have questions, just raise your hand and we'll try and address them as we go. What we're going to ask you to do today, just so that we can stay on time, is hold your questions. And at the end of each presentation, we're going to try and leave some room so that we can answer the questions you might have. Or feel free, we've got lawyers and Robin's going to be here. We've got people all over the room. And during the breaks, we'd be glad to address any question you might have. There's still a lot of unanswered answers out there for questions. So if there isn't an answer, if we need to go back and look, we'll do that and get back to you as quickly as possible. But again, thank you. I think we've got the seating taken care of, but please squeeze together and bear with us today. My name's Richard Nix. I'm the managing partner with McAfee and Taft. For the last 27 years, I've also participated in the Employee Benefit and Executive Compensation Practice Group. And as I mentioned, this is kind of a new day for all of us. And we're excited to work through this with you. And as we go through here, we're going to have 3 different panels. And we're very fortunate today to have a national speaker with us. Robin Piper is with Piper Jordan. It's a national consulting firm based out of San Diego. I'll introduce her in more detail in a minute, but the first panel will be Robin and then our own Bill Frudenrich. And that's going to be more of a 40,000-foot, here's what the law looks like, go down a little bit further as to implementation. What is it that we could be doing proactively and not reactionary? What are others around the country doing as it relates to this? And we find that to be the best approach right now, with the understanding that the answer to those questions today may be different tomorrow, the next day. I mean, we've got November coming up. We've got elections coming up. We've got all sorts of implementations. We've got notices. We've got regulations that are proposed in this. So as we've historically done, we will be setting up seminars and webinars as it relates to new information as it comes out. You'll be getting emails on that as well. And we'll try and keep you apprised as much as possible as we go through this. And as is always the case, we're in this together. And we understand and appreciate the importance of this. When I started back 27 years ago, health insurance and quite frankly the 401k was really just a throw-in. The only thing a new employee really wanted to know about was compensation and bonuses. The health insurance was kind of a dime a dozen. Every one of them kind of looked the same. Fast forward a few years, the 401k and the retirement plan programs became a little bit more popular in that, because people realized that if they were going to retire how they want to and when they want to, it was dependent upon them to save money, both with employee and employer dollars, in order to retire. Now, health insurance, if it's not the second or third question that a new hire asks you, it's in the top 5 typically. And in order for you to compete and keep, attract, retain, and reward your key employees, health insurance is a vital part of that. And this has completely changed how employers, and now we're going to have to educate the employees, are going to have to look at this. So that's our process today. The first panel will go at 40,000 feet. The second panel will be Bill Frudenrich, Jim Prince, and John Paparonis, all of which McAfee Taft lawyers. They're going to address and spend most of the time on the pay or play. The big issue, are you going to stay in the health insurance business? If you're like many employers, the knee-jerk reaction is fine, I'll just drop it. I won't play. I'll pay the penalty, the tax, whatever you want to say. But is that your best option? And the answer to that, in our opinion, and what we hope you take away today, is it depends. Make sure you get all the information. Yeah, how's that? And I'm not sure that answer is going to change anytime soon either. But what we want you to do is make an informed decision. Every employer is going to be different. Every situation is going to be different. And unless you have all that information in front of you to determine whether or not can you keep the good employees that you have if you get out of that business, how much is it going to cost you really? What are the other options do you have? Health insurance costs under this, they're going up. They have to. As Robin has said in talking to her, I mean, this was really not a reform, healthcare reform, as much as healthcare expansion. More people are involved, and there's going to be additional benefits. There's penalties associated with, there's fees associated with this. So how do you contain your cost? And sitting there hoping that it goes away is not an option anymore. I think that was kind of the game plan and the strategy for not only employers but a lot of consultants, hoping that the Supreme Court would come in and potentially save the day, not even knowing what that meant. So the second group is going to talk about, and the second panel will talk about the pay or play. And the last group, and what we're going to do is go from, the first group will go 8:30 to 9:30. We'll have a 15-minute break. We'll then go, the second group will go for 50 minutes. We'll take another 15-minute break. And then the last group will be, John Paparonis will be moderating it with Allison Patel and Brandon Long. And they're going to talk about some specific aspects. Okay, what do I need to do now? Flexible spending accounts, W-2s, the penalty aspect of things, and go into really kind of a little bit about a lot of different things. And so we didn't have any problem filling the 3 hours with the information. Our objective today is to get you as much information as possible. As a result, the materials you have in front of you, we probably, and we won't be able to cover in the detail that we'd like to, but we're trying to be conscious of your time, and at the same time, it scares me when he goes behind me. Oh, okay. Our objective is to get you as much information as we possibly can and still be respectful of your time. So with that, let's get started. Today, our guest speaker, she is from San Diego, and
not a native. Huh? Not a native, though.
Not a native. Illinois, we had some good stories. Small town girl, but she did bring, it looks like, her weather with her. Because I don't know about you, but I wish we were having this seminar outdoors. It's beautiful out there. But we're certainly fortunate to have Robin with us. She formed the Piper Jordan consulting firm, a number of years ago in 2006. Mm-hmm. And she's been in it's a national consulting firm in the benefits area. And she travels all over the country. For 19 years, she specialized in a number of different areas, but specifically in the healthcare consulting side of things. And that has garnered her not only the respect in the private sector, but she has testified on several occasions in front of Congress, and she's working with them right now on the healthcare matters, the affordable healthcare process. And she's working with the Treasury, the White House, with congressmen and women on both sides of the aisle to figure out how this applies to employers so that when they're issuing these notices and the regulations that they have input from the practical side of things. So we feel very fortunate to have Robin with us. She's going to be here for the first panel. Afterwards, if you have questions, I'll volunteer you, Robin. She'd be glad to talk to you about your specific situation. But with that, would you join me in welcoming Robin to the podium?
Can everyone hear me all right? Hopefully. I had some difficulties with my with my microphone today. So obviously, I need to say thank you and good morning and wow. I speak across the country frequently. Now, generally what I'm dealing with are conferences and I'll have somebody like last week when I was in Vegas, somebody came up to me and said, ugh, I'm the comp guy and my boss made me come to this. I don't get that from this crowd. You voluntarily came. This is an amazing testament to your firm. I know I keep saying that, but I've been pretty blown away with how much this firm is respected. So it's absolutely an honor to be here today. In a nutshell, and I know we don't have a lot of time, and I have something like 150 slides. I'm just teasing, like 65. But there's a lot of topics here. Certainly, I know that we have a mixed crowd here. Some of you have some experience. Some of you have less. I'm going to be telling you some things that you probably already know. Hopefully, there might be one tidbit in here that comes as a surprise to you. And the way that I have this laid out, is there a power button on this? Yeah. Oh, there we go. I thought it was already on. I'm sorry. It does say August 21st, so bear with me. I thought I was speaking yesterday. So here's what I want to cover. I want to talk to you a little bit about the core, because, look, this law is about 3,000 pages. Okay? And my experience comes from the fact, and plain and simple, I was a squeaky wheel in a very confusing time, period. So I'll be sharing some of my experience with you as we go through this. But it's important that you understand a timeline, really more or less from my perspective, which I'm not telling you exactly the dates that you need to comply with it. I want you to be thinking about what you should be thinking about in a futuristic standpoint, right? We don't want to talk about the employer shared provisions in 2014. We want to talk about them today. So we'll spend a brief amount of time on the timeline. I'm then going to get into the nitty-gritty on topics that we all love to talk about, like the PCORI fee, right? And the W-2 issuance. I'll touch upon that. We're going to talk about the exchanges because we're in a final reg on that. The premium subsidies, final reg on that. We'll talk about the employer reporting, okay? And then ultimately, we'll get to the good stuff, which is really how do we optimize this. So I'm going to make you go through the boring details before we get to the good stuff, so you all have to stay in the room. But the reality is that, as you said, this is not a cookie-cutter approach, and I know it got a good laugh. The reality is that any of us would be foolish to tell you we know exactly what you should do today. It takes a whole lot more of our attention to take a look at what your eligibility is, what the current plan designs are, what your corporate philosophy is, and that's what we're going to talk about at the end of this. So here's the core. I mean, these are the items that we really all know, right? Passed on March 23rd, 2010. And I have a real bad tendency to not follow the exact pages on this one, so bear with me on that one. I'll try to keep you as pulled into the presentation as possible. This was really, this green bar is really where things sort of went a different direction. So it's passed on a Sunday. It goes through a period of reconciliation. What came out of that was the manager's amendment. I was anxiously awaiting that manager's amendment, and it arrived in my email at about 4:23, 4:35 on a Friday. And I read it, and I gasped. I was honestly terrified by some of the things that had changed in that week because it really hit my employer segment hard. I specialize in groups in 10,000 plus lives. So for those of you that are a small group, here's my involvement in a small group. We write a number of restaurant accounts, anywhere from 10 to 80,000 restaurant employees. And we do a lot of franchise work. We have a special unit that works on franchise. So when I took a look at how it impacted the small employer, again, big gasp. So I was a squeaky wheel. I picked up the phone and I contacted a few individuals that I knew in Washington, and that really became a journey for us. We've been able to put together white papers for the Department of Labor. We've testified. We really have our finger on the pulse of not just what was passed, because anybody can read what was passed, albeit none of us want to read what was passed because it's just dead boring, but what they're about to do. And I will share everything that I know with you as we go through the presentation. So as we refer to, whether you call it PPACA or PACA, or for those of you who have been paying attention, no one in the industry calls it either of those anymore. We refer to it as the ACA, right? So this slide right here will probably give you more than you need to know. This is the healthcare reform law in a nutshell on one slide. You don't need to read the 3,000 pages now. Very, very simple. It increases access to health insurance. It expands market requirements. And it pays for all of this by increased taxes and cuts to Medicare. This is it. So as long as you understand what this is, then you can sort of drill down to the minutia of the details. Here's your increased access. Now, some of this we haven't gotten to, and some of it we already have. But we're going to have a high-risk pool for uninsured individuals. Of course, that's going to get paid for in much part on the fees that I'm about ready to talk to you about. You had a reinsurance program for the retirees. Some of you may have taken advantage of that a couple of years ago. For those of you that are a small business, there's some tax credits there for offering health insurance, right? And states can voluntarily expand their Medicaid program. That's been in the press a lot, much, much more so in May and June as we led up to that Supreme Court ruling. We had 26 states who were party to that lawsuit at the Supreme Court level. Now, it is very common for the federal government to throw something out there that's called the federal funding mechanism to incent states to comply. And that is what those 26 states were fighting. Now, ultimately, if they chose not to voluntarily comply, it could have, now these are estimates, but these are across the board with industry experts, could have increased their taxes up to 22%, which would have raised taxes in that state by 36%, up to. But basically, the federal funding mechanism is borne 100% on the backs of the federal taxpayer. This is why the states were all up in arms. And honestly, we don't have any idea as to which ones are officially going to stay out or in. That will remain to be seen. Your market expansions, Medicaid's going to be expanded to the non-pregnant, non-elderly, right? We've already talked about the Medicaid expansion funding. CHIP structure, pretty much going to maintain the current CHIP structure. You're going to have the state exchanges for small employers. And this is a little confusing. State exchanges right now, small employers and individuals. If you're a large employer, don't think about the state exchange. Okay, there are some rumblings of the private exchanges that will be out there by some of the larger consulting firms. All brand new stuff, guys. So in 2017, we are supposed to be able to open up the state exchanges to the large employers. Again, we haven't seen a lot of states hit their targets on their deadline, so we'll see if that happens. And then, of course, we're going to have the individual mandate. I love this slide. I wanted to make sure you all saw it. It gives you the math. This is great for you that are the CFO or you're in the accounting department, right? So this is recent. This is the most updated numbers. And this came from a February, there was a baseline projection, and then it was updated in March of 2012. So they're talking about reducing federal deficits by $210 billion, all right? Now, when you look at the law's coverage expansion, cost of that estimated, updated in March of 2012, is $1,496 billion. Now, somebody asked me in last week's presentation if that should not be trillion. I don't know. I can just tell you that's what the CBO and the JCT have it in their report. So I can't go back to high school on this one. They are assuming offsets for what? Your individual and employer penalties, the excise tax on your Cadillac plans or the high-cost plans, right? And insurance or net savings from some programs. But that's why we're here today. This is all subjective. The reason why you're going to be listening to 3 hours of fascinating dialogue on healthcare reform is so you can avoid those penalties, right? And we can teach you how to avoid or at least delay that excise tax as long as you possibly can. They're not expecting that we're all having these conversations. So these numbers, again, are subjective. So then when you take into consideration in the last section here, assuming spending savings, these payment delivery reforms that they have, they're stating that it's going to be $1,252 billion. Easy math here. That bottom section, $1,252 billion minus $1,042 billion, gets you to your $210 billion that they believe that we're going to be reducing the deficit by. Just good numbers to have, at least I think, because I love numbers. This is how you pay for it, other than the fees, right, that we're going to be talking about a little bit here. Extra taxes on their definition of high-income household. We're going to reduce the FSA plan to $2,500. We are going to remove over-the-counter drugs from the FSA plan, except for insulin. And most of you are probably working on that because it applies this year. These are popular measures. Should be communicated. I think employees, unfortunately, are going to be in a situation where they believe that we're taking away something from them. And I know that that's the reality. And it's that slippery slope. What do you communicate with them? Do you tell them that this is part of healthcare reform? Do you just let it be and not get involved? I mean, certainly that's, I have clients that are across the board on this. But this last piece here is really, this is what they expect to see by 2021. 82% of the non-elderly are covered right now by insurance. They think they're going to get it up to 93%. It remains to be seen. Timeline. I know I need to cruise through this quickly on this. There is a method behind my madness as to why I'm stating the obvious on this. But let's talk about the first couple of slides, right? These are the items we've already gone through. Age 26, pre-X under age 19. We've gotten rid of our lifetime limits. Everybody knee-jerk reaction, even on our core salaried plans, we got rid of those annual limits. Although we got rid of those annual limits without really understanding that we could have had annual limits on non-essential benefits. It was just confusing times. So, of course, we're going to talk about that. But a lot of employers right now are modeling and putting limits back on as long as it's non-essential health benefits. And again, don't be too confused. We'll touch upon it here in a second. That the internal external appeals, if I had groups that were terrified of losing grandfathering, a lot of it had to do with 105H and the appeals process. 100% of our groups have lost grandfathering at this point. You had to. I mean, look, and I say this, and I'll probably say it 20 times during this presentation, but the healthcare reform law is aggressive on you. Therefore, we have to be aggressive back in our strategy. And that doesn't mean you have to pull everything back for the employees. We just have to change strategies. As he said, it's irrelevant how we got there or got here. We just need to readjust. In 5 years, well, I think we'll all remember this. But we won't remember it as much as it feels today. So the reason I bring these up, we've already gone through these. I've met with the Republicans. I've met with the Democrats. Republicans will tell you, if you're behind closed doors, repeal is for show. It is to put it on the docket that they had the vote. Replace is probably the bigger strategy. Now, annual limit plans remains to be, for those of you that may have a mini-med plan, I don't know what will happen with those. Will they really take an employee off of that coverage if we're in a Republican presidency and a Republican Congress? I don't know, and I can't really talk to that detail today. But I can tell you that these two slides are what everybody really thinks that probably will keep on our plans, okay? What you need to be thinking about now, again, I am so glad I did not have to talk about the summary of benefits coverage because it's just so detailed it drives me crazy. But you all need to be thinking about that now, okay? If you're self-insured, guys, be talking to your TPA or your ASO vendor. If you're fully insured, there's a lot of tools out there to help you get by it. I don't think it's a bad idea, and I've mentioned this a couple of times. I hired this woman straight out of college, and she saw what we did for our clients, and when this all came out, she said, isn't this what we already do for our groups? Because we do great detail in making sure things are uniform, and we do a lot of claim examples, which I've always found to be incredibly useful, because we understand it. It's super hard to understand when you're not an expert or you're sitting at the HR desk or the benefits desk. Claim examples, I think it's great. Do I like all the detail behind this and the fines? We just have to remember at this point in time, a lot of this detail is for willful violations. If you're giving it your best effort here, no one is anticipating, especially the first year out, that anybody's going to be hit with the penalties. Just do the best you can. We are going to talk in more detail about this on our third panel. Yeah. So we gave Robin a reprieve on having to go through that. I was thrilled. So W-2 reporting, it's going to be in this slide and the next one. If you didn't do it last year, need to get it going. Make sure that you're up and ready to do this. Preventive services, most of you, I believe, I'm sure, probably already incorporated this into your plan designs. And then, of course, you're faced with the ugly responsibility of notifying your employees that the FSA is going to be changing. 2013, again, I need to be quick on these, but if anybody thinks that the employees won't be alerted as to what the exchange is going to do and what their rights are under the exchange, Oh, yes, they will. It's going to be like the commercials that we have about preventive care. We will be letting them know. We were supposed to let them know at the end of this quarter. It's been delayed. We don't have the model notice at this point in time. So understand, we've got to get this out next year. They will know what we have to do if we're going to be running an employer-sponsored plan, that it has to be affordable. If it isn't affordable, check the math, check their paycheck. They can go to the exchange. Obviously, we have the PPACA fee that's up right now. Now, don't get me wrong, there's other fees that are out there, but the PPACA fee is the one that you should be tallying up, because if you have a calendar year plan, you're paying it next July. And then, of course, the payroll tax, Medicaid or Medicare, and I know all of these are going to be talked about in the next segment, so the retiree Part D subsidy. These, primarily, are the pieces that I'm going to be talking about today. So to save me the 35, 45 seconds here, I'm going to skip this. So let's just get into this at this point. So here are the game changers. We've got a general election in November, right? Repeal is not the Republican strategy. They're going to say that. Replacement is. I think the head scratcher on this one is we just haven't seen it. I haven't seen it. All right, there's some rumblings as to what it will be, and I don't know when it will be announced. So it would be great, from a planning standpoint, if we could see that. But at the end of the day, we need to see what happens in 2012. This is a total business issue, and it is a case-by-case scenario. So as much as I can, I'll try to drill down to your individual circumstances. But just so you understand, he's dead on. This isn't cookie cutter. State issues, obviously they have to make a decision as to whether to allow what type of exchanges they'll allow. We'll get into that in a minute. They need to make a decision on whether they're going to expand Medicaid. And obviously we've had the repeal and replace votes in the House, maybe a vote on the Senate floor. And of course you probably have seen the publicity and on withholding funding, especially on the PPACA fee. So let's talk a little bit about minimum value plans. And these, let me tell you the strategy that we've had for our groups quickly. Eligibility is something that we wanted to analyze from day one that this was passed. We're probably in our third version at this point in time. From a plan design standpoint, we wanted to make sure people were in a position of strength, so we were not hitting that excise tax. So these are all incredibly important. Even if we end up with a complete change in November, you really need to be thinking about these things now, at least to understand where you are, to understand what you may have to be executing on. And especially as you go into your 2013 renewal, you may want to make these changes now. I would say 75% of our book of business made plan changes last year, 50% last year, 75% this year. So this is the actual definition. The plan share of the total allowed costs of benefits provided under the plan is less than 60% of such costs. There's a visual on the next slide, because that just doesn't make a lot of sense to anybody. But if your plan fails to meet minimum value, then that puts you into a situation of the penalties, which the next panel is going to speak more about. But remember, there's two. There is a no coverage penalty, and there's what is called the unaffordable penalty, which under that scenario, you have to offer minimum value, and then it has to be affordable. And I'll let the next crew talk about the affordability piece a little bit more. There is something that HHS released. It's called the Actuarial Value and Cost Sharing Reductions Bulletin. If you put that in Google, it'll pop it right up. I think it's a great little piece to print and have in a file or just save it, because you will have questions internally. You're going to want to talk to your consultants, your brokers about this, or your carriers, or whoever it is that you're working with, to understand this a little bit better. It really gives a great definition for small employers. And then, of course, it gives a couple of visuals on this, a couple examples as to how you would define the actuarial value. Now, if everybody can see this, and I know it's a little bit lower at the end of the screen, but you want to think about the health care costs paid by the plan. So taking into consideration deductibles, co-insurance, co-pays. So what the plan pays, right? Divided by the total health care cost. So for every dollar that comes in, they want you to at least, the plan pays 60%. All right? So still gets very confusing with co-insurance, but Again, I would really recommend that you pull this up, take a look at the examples. They're extremely helpful. All right? There are some assumptions in the, and I had to abbreviate, other this PowerPoint was going to be 300 pages. MV, minimum value. It's much easier in the small group market because you're talking about the essential health care benefits. All right? And there's 10. And we'll go into that in a minute. For those of you that are self-insured or you're a large group, head scratcher, you don't have to pay attention really to the 10 EHBs. You're not required to. But if you don't, your plan's going to have a hard time getting to a 60% actuarial value. I mean, the reality is the 10 essential health care benefits are really the benefits you already had in your plan anyway. You pull those out, you're not going to get to a 60% actuarial value by paying for fertility costs and chiropractor, right? So it's a little misleading, and we'll talk about that in a little bit more detail. HSAs and HRAs, if you offer them, you can include them in the actuarial value. Word of warning, don't be that crazy about what you're putting in there. So if you do a $1,000 HSA, you can't go, oh, I've got 1,000 employees, I'm going to put in $1,000 times 1,000 employees, add that in. Each one of those 1,000 employees is not going to be tapping into that $1,000. Look at what you did years prior, work with your experts, come up with a reasonable expectation is what you think will happen in that plan year. Don't overstate is the word of warning on this one. You know, and again, EHBs applies to small group, does not apply to large group, does not apply to self-insured. I've already talked to you about this one, so we can skip that slide. Here's how you determine minimum value. There's 3 different means here. It is actually, I don't want to take the confusion out of this, but it is relatively simple. There are calculators for an actuarial value and the minimum value. They're going to be on websites. You can sit there with your plan details and just click in the details, and it's going to come up with a calculator like that. All right? Then there's safe harbor checklists. Again, and these really, for the most part, the calculators and the safe harbor checklists are for plan designs that are pretty standard. Right? That doesn't mean that you can't have vast differences in deductibles and copays, but that's standard health insurance design, right? So there are safe harbor checklists, and if you're cruising down, it says you got to have at least a $3,500 deductible. Check. At least have a 60% coinsurance. Check. If you're checking and you're meeting or exceeding, you pass. Don't throw that piece of paper away. Make sure you file it in case you have an audit, right? The other, actuarial certification, there'll be a price tag to that. You need to get your actuarial partner or your consultant to be able to do this. Really, at the end of the day, you only need to do this if you have some unique aspects to that plan. And probably the best example I could give you is, remember, you can't have annual dollar limits, but you can have annual limits on services or days. So let's say that you had a limit on mental health care counseling, right? So if you have a day limit on that, you can probably, or even more complicated, a day limit if you can only cover 10 office visits for physician services. That would be something that would be a little bit more complicated that a calculator can't do for you. I love this next report because it just really sums it all up. In 2011, HHS released a report that said 98% of individuals are already covered by a 60% actuarial plan. So you have to remember, and again, I say this all the time, the federal government has now told you that a 60% actuarial plan is pretty good coverage. We're all up here. I mean, is there anybody in here that always offered 60% actuarial value plans? 2% of American employers provided something that was less than that. We've all been up here. So when the government tells us that we can be down here, we're all shaking our heads going, I'm not sure what we're all doing at this point in time. We're giving these great benefits. Then what they said is that the 4 greatest categories of benefits are physician services, diagnostic X-ray and lab, pharmacy, and emergency room. Is there anybody that didn't already know that? Yes, we already know that, right? And what's interesting to me is as we talk about going to a 60% actuarial plan, where are these benefits at? Are these catastrophic? No, they are not. They are on the lower We hit them at first dollar, usually. I mean, hopefully we have a deductible or a copay on the emergency room because the usage is so excessive, right? But the reality is that now we're looking at a 60% actuarial plan, and what do those look like? Anywhere from $3,500 to a $7,500 deductible. Your employees, if you're offering this, will have to pay their own first dollar coverage, right? A woman's median outlay on a high deductible health plan is about $1,300. That gives you an idea. So when you're talking about expanding coverage to people who are the lowest income, again, not your problem to try to solve this. I mean, I find this to be interesting. The market expansion and the access to insurance was really more or less for catastrophic. Essential health benefits. We've already touched on this because it really applies to what I was talking about with minimum value. Again, one more time, guys, if you're small group, absolutely make sure that these 10 EHBs are part of your plan design. If you're a large group, you take a look at if you're offering those EHBs, you cannot have an annual maximum, dollar maximum on an EHB, a dollar annual maximum. Again, so there's a difference between the dollars and the per service. So also understand how removing one of those EHBs would upset the apple cart as it relates to your 60% actuarial value plan if you choose to put that in. I've already covered a majority of this. The last bullet point, benefits that seem to be the most in question is to whether you include these or not. Fertility, chiropractic, acupuncture, hearing aids, vision LASIK, and durable medical equipment. And if you're California, which, again, I just visit California once in a while. I'm on a plane most of the time, but acupuncture is a super trendy benefit out there. So I can tell you the California employees would be devastated if that were pulled out. Here's your EHBs. And again, this is overly simplistic. This is what you already probably had in your plans. Ambulatory patient services, hospitalization, emergency services, maternity and newborn care, mental health and substance abuse, prescription drug, rehabilitative and habilitative services, lab, preventive, and pediatric services. All right? Small employers in, large employers, you can use some modifications of these, but you're not going to be able to get too crazy on those. So, employer shared responsibilities. Again, some of this you're going to hear later. We're going to talk a little bit about the safe harbors, more or less. But as you know, again, 2 penalties you need to pay attention to. Don't let anyone tell you, and I mean this, because I've heard some interesting stories, that you fit into one of these equations until you've taken a look at the math on this. I would not, and I know the knee-jerk reaction on May 23rd was we're out. I mean, everybody was like, that's it, we're out. Then it got back into, no, we can't be out. It's too much of just the employer. It's just part of our philosophy. A majority of employers are going to stay in the game. They're going to play. What I will tell you is that they're playing and re-engaging. A full play, I don't care what happens in November, a full play, most employers are simply just considering to be irresponsible at this point in time. We almost shot ourselves in the foot here in the first place. This is why we're here, because it's not working, right? We're increasing at 8 to 11% annually. So something needs to change, and the best thing that I think healthcare reform law has done is it's opened up the floodgates. We're having these conversations as to how to make it better, because honestly, I feel like we're the only ones that can handle fixing it. So let's get into some of these safe harbors and definitions here. The law was passed that 30 hours a week is your full-time definition. Now, originally it said that they wanted you to reconcile this on a monthly basis, which just is amazing to me. I don't think anybody in Congress happened to be an employer. We think weekly, we think biweekly, we think quarterly, we think annually. We don't think monthly. So I will tell you they have made some accommodations, thankfully, and here are our gifts, 2011-36 and 2011-73. And again, I try to do this. I usually don't put as much detail in the bullets, but I thought that this was good for you because you can pull up something like that on Google. You can go ahead and take a look at this section, so if you want to read it in a little bit more detail. But 2011-36 goes into a look-back stability period. We'll go into that in a minute. Some of you, it will just do you no good. For those of you that have employees that you did not provide benefits to, right, that were hourly, or have a lot of part-timers that fluctuate hours, hugely important for you. 2011-73, when they say affordability, in the beginning, they wanted you to base it on your employee's household income. That meant you would have had to have collected every person's W-2 in that household. And it wasn't just to spouses. It was to anyone who brought income into that house. So we have a safe harbor. Now, granted, this isn't a final reg. Do I think they're going to change it? No, I don't. But we need to talk about that as well. Here's 2011-36. This is how you count an hour of service. If you have an hourly employee, it's really simple. You count the hours that they're paid for. Counting the hours that they are paid for does include paid time off, military leave, sick pay, vacation pay, and it also includes leave of absence up to 160 hours continuous. If they are not, and you're talking about salaried, then you certainly have a few different definitions, right? You could literally count hours, or you can do what's called a day's worked equivalency or a week's worked equivalency. And really, that means if you do a day's worked, if they work 1 hour, you give them 8 hours. And the week's worked is if they work 1 hour in the week, you give them 40 hours. It's all about your HR policies and your PTO plan and whatever you deem to be the easiest for your company. You can use different methods for different classes. Obviously, you have to use the hourly employees as one, and then your salaried group is another, right? And you can change annually. Isn't that nice? Okay, I'm going to have to go really fast because I know we're getting to the point where this is, we need to open this up to questions. And look back stability. Do I have anybody in the crowd that has hourly employees? Okay, all right. For your existing population, because the new hire rules are different, as you enter January 1 of 2014, you need to, do a look-back stability. You can look back 3 months, 6 months, or 12. If you look back in those periods that are allowed, those are the only 3 that are allowed, you define who is above 30 hours and who is below. For those that are above 30 hours, you have to keep them on your plan during a stability period of 6 and 12. 3, 6, 12, 6, 12. This really does not apply to those of you that have consistent employees by job title that you hire that work at full 30 hours a week. And the best case example I can give you is every restaurant employer I've worked with will tell you that their shift leaders work over 30 hours. I wouldn't try to mess with the shift leaders. So this is for your fluctuating hourly group. All right, and here is an example of this. If you do a 6-month look-back period, this individual works 122, 143, 114, 151, 118, 135. You add up those hours, you divide by 6, you have a full-time employee at 130.5 hours. I don't care if in the stability period, if they work 2 hours a week, you're keeping them on the plan. The reason why this is critical to talk about, if a 12-month look-back fares better, gives you fewer employees, when's your clock start ticking? January 1 of this year. And I know a lot of employers are trying to change eligibility definitions, understandably so, to try to protect themselves. I would not recommend that you start doing this on the 4th quarter of 2013. Okay, there are ERISA implications that your wonderful law firm here can talk to you a little bit more in detail about. Employers that are looking at just saying, look, okay, we can't have this fluctuation anymore. We either have titles, job titles are in, or they're above or below. They're making those changes now. So the best advice I can give you is analyze it, make decisions by 10-1, sit on it and wait for that election, which is fine. If you need to execute, you execute on January 1. All right? I'm not going to go into 2012, 17. You can look it up if you feel like having a heart attack after a cup of coffee. The reality is that they're changing it. Santa and Treasury called 2 or 3 weeks ago. They know that it's bad. They're changing it. I can't tell you it's going to be beautiful when they revise it. We're expecting to see something this fall. 2011-73, very quickly, we're basing it off of W-2 wages. We're not basing it anymore off of household income. And you've got to remember your affordability as passed is based on that single tier. Little game changer here, Treasury's looking at extending it to the dependent tiers. So much so that the exchange rules have been held up because of it. Do I think they're going to change it? I do not. I think that would just blow employers away. If all of a sudden we had to start collecting W-2s and defining household income, it's just not possible. I can tell you, though, that they're thinking about it. Again, we've talked about this, so let's give you the 3-minute overview on the next few slides here. Primarily, I bring up the exchange because you need to know how employees can go in and out. Your job is to provide minimum value coverage that meets 60%. The subsidies in the exchange are at the silver level, which is at 70% actuarial value. So good news, bad news. They get a little bit higher on the actuarial value, but it's a little bit more premium, right? Because it's a higher value plan. So, of course, the exchange has 4 metal tiers, and there's something called the Young Invincible plan that we won't go into. Essentially, the exchange is going to be a benefits outsourcing administration company. Really. They are a single point of entry for eligibility, meaning that the employee applies. They first try to see if they're eligible for Medicaid or CHIP. They then try to see if they're eligible for the exchange. They then try to see if you do not have minimum essential coverage. They check on what you're doing. They handle the premium. They have a call center. And they reconcile, they accept payments, and they handle the terminations. They have a lot of work to do. It's hard enough for us to be able to figure it out. This is how fast I'm going through this. It's going to drive you all crazy. Exchanges are going to be broad. They can have multiple. It can be a nonprofit. It can be a for-profit. It can be group exchanges in different areas. You can have 1 exchange, 5 exchanges. Okay, we talked about the eligibility process. What I really want to get through to you on the employer side is that there are set open enrollment periods right here, last bullet point. This is, again, 2013, you're going to provide an exchange notice at some point next year. They then will have open enrollment from October 1, 2013, long period of time. We give them a lot of time to do this, to March 31. If they enroll by December 15th, they'll have January 1 coverage. Thereafter, October 15th, it really matches almost the Medicare open enrollment period, which makes a whole lot of sense. October 15th through December 7th. Now, you, as the employer, again, they're looking to see whether you have affordable coverage. They're looking to see whether it meets minimum value. There is a safe harbor that has been mentioned that will allow the employee to stay in the exchange plan for a year so they're not going in and out. It's really confusing because they also reference the fact that you're only liable if you were unaffordable or not meeting minimum value for 1 month. I mean, there's language in all of these releases, if you will, that and the law itself that states that you basically assumes that you can make some changes, right? Let's say you've got an hourly employee that was working 30 and maybe they dropped hours and oh my gosh, that means they earn less, right? You have to be crystal clear together on your payroll system and what type of reports that you want to see, especially if you are at that danger level. To give you an idea on this, $15,303 is the highest dollar amount that an individual can make in order to be eligible for Medicaid. Above that is the exchange. So when you take just $15,303 divided by 30 hours a week, that gives you $9.81. Just use that as an idea. The exchanges can terminate people, and even if they enroll, this is interesting to me, even if they enroll with you, and you didn't have minimum essential coverage and you weren't affordable and they enrolled with you anyway and didn't opt out in the applicable time, they can't go into the exchange. So, look, the reality is we're going to be giving them a lot of information to read on what to pay attention to. You are going to have auto-enrollment period. You need to give them an opt-out period. If they opt out and you were affordable, they still can't go to the exchange. Okay, so I think originally we thought that they were going to go in and out whenever they felt like it. There are rules to protect the exchange now. So, I think that we need to move on this pretty quickly here, right? Because we're at the point in time.
You got 10 minutes.
That we need to get through this quickly. I will say this, as you start to think about what your termination rules are, the exchange allows 90 days to pay, okay? And in order to pay, or if you don't pay, you're terminated to the last day of the first month. So for those of you that have hourly employees, we don't have the regulation on this yet, but it would be something I would be thinking about for that 90-day period. Premium tax credits, again, we are unknown in a few areas. They have withheld information from us on the final reg as it relates to related individuals. Why? Because Treasury is looking at whether they're going to extend the affordability to your dependent tiers, i.e. employee plus one, family. Okay? Also, they have, I will tell you, they've withheld information on wellness plans. If you think about a HIPAA wellness plan, you can have a 20% differential right now, right? 2013, it's going to be 30%, possibly 50, but let's just go with 30. The reason why they've withheld information is because logically, if you have a good wellness program that qualifies for a 30% differential, why should you be responsible if that employee doesn't meet the definition of staying within that wellness program? Smoking, why should you be responsible to have the affordability at the smoking tier? I don't know the answers to that. I can tell you that it's being thought about. HHS is part of a study that they're conducting right now, and certainly the premium tax credit final reg is withheld, has stated that that's information that's outstanding. Look, in a nutshell on this one, which is interesting, the employee has to be a taxpayer. They've got to be a citizen. They can't be incarcerated. Now, I can tell you on my large groups, I do have an issue with some employees being a taxpayer, but this is the reality, okay? It's based on family size. It is complicated, and you do not need to manage it. Thank goodness this is one thing that you do not need to do. The exchanges will be that single point of entry. They work with HHS. They work with the IRS, and they are going to be verifying what you are doing through reports. And I'm summarizing 5 or 6 slides into a very small window here, but we're going to be talking about these reports. And again, what I would encourage you to do, and I know some of you just simply want to wait until the election, at least find out what you would need to do to get these reports going. They are complicated. You want them to be right? Because if they're going to come and verify information, you want this information to be correct. Again, in the effort of time on this one, I really have already given you this information. One thing that I believe is probably good on this is that if you go to the final regulation on the premium tax credits, gives you 8 examples of affordability, takes the sting out of it a little bit. It's really good to take just 5 minutes to talk about that. It also talks to you about the employee safe harbor, and it definitely discusses the wellness piece of it. And one thing I should also know, the safe harbor, if that employee goes in and they say, okay, we're just going to let them stay there, we're not going to penalize you any longer, we're going to let them stay there, is an annual basis. Now, employees are supposed to notify the exchanges within 30 days if they have an event that causes them to fall out of the affordability. I'm not guessing that a lot of employees are going to alert HHS if you all of a sudden increase the plan value, but that's what's hypothetically supposed to happen. We have already touched on this. I've already talked to you about the automatic enrollment and how they terminate. I've already talked to you about the affordability. Employer reporting. Look, for large employers, you have 2, and they look almost exactly the same. But ultimately, they're drilling down to employee-level detail. They want things like either an identification number, an SSN. They want dependent-level detail. They want the dates that the individual was covered under the policy. They want your information, plan design details. I have a lot of groups that are, I don't care if they're 5,000 employees or they're 120,000 employees. They're missing pieces of this information. So data accuracy is a huge piece of what we're talking about now. And again, Look, our position on this has not been to just sit there and wait until November, because these are things that really we should have gotten a handle on before anyway. Most of our groups are trying to be proactive on this. I will be very, very, very brief because, again, we have so little time to continue talking about these details. But, again, take a look at these report details. Understand that I would be talking to your HRAS group, your payroll department, your outsourced vendor, whoever manages that data. Sorry to go so fast, but I'm here for the next few hours, so if you have more questions, please. I wanted to make sure that I brought this up. Your next group's going to be talking about PPACA. There has been very little information on the transitional reinsurance program and fee assessment. And it's a little scary, okay? If you're insured, the insurer needs to pay for it.
No.
It's slide 58. Oh, do they not have it?
No.
Oh, ignore it. I'm so sorry. No wonder there's so much flipping. But I'm going to talk about it because you need to understand it. If you're fully insured, the carrier's supposed to pay it, but they're going to pass it on to you, right? If you're self-insured, you have to pay it, okay? Again, these are the three fees. The insurer has a fee, you have the CORI, and then you have the transitional reinsurance fee. And no one's talking about it, which drives me crazy on this. Here's how much revenue they believe that these fees are going to pick up. PCORI, small, about $5 billion. It's tiny. Annual health insurer fee, obviously they're expecting about $60 billion, and the transitional reinsurance fee is about $25 billion. This is how we're paying for it. It's 3 years. Okay? It's meant to pay for, you have to remember, those are the high-risk pools, right? States can bring on individuals into these high-risk pools. They have no clue what the conditions are going to be on these people. No clue, right? Terrifying to them. How are they going to pay for the unknown cancers and heart disease? By this fee that you're all going to pay. This is what the revenue looks like, okay? $10 billion, again, it's for 3 years. $10 billion in 2014, $6 billion in 2015, $4 billion in 2016, and then you've got $5 billion out of the ERRP. It applies to you whether you're grandfathered or non-grandfathered. It is not the PCORI, so do not confuse it as such. 3 years from 2014 to 2016. It applies as to whether you're insured or self-insured, which I've already said. And this is a little confusing. HHS has the authority over this one. Treasury has authority over PCORI. So we could have some different definitions here. And more to come. This is by no means final. The assumed estimate is between $61 and $105 per capita. PCORI is $1 that you pay next July. And then the following is $2. This is 61 to 105. Pay attention to it. Talk to your insurers now, or your ASO vendor. Find out how you think this is going to impact your consultant or your broker. Definitely, definitely, definitely you want to have those conversations now, especially if you're on the smaller or the fully insured side, because states can hit you with more fees on it. $100 per day on a per affected individual. And look, they're expecting to collect on a monthly basis. That's really, at the end of the day, here's your big tickets that we need to talk about. I'm sure that just made your day. You didn't see it in the presentation. These I can go fast on. Auto enrollment, we have no clue when that's going to be. Probably 2015. Okay? Not enough rules on it. If you look up 2012-17, which I told you, don't pay attention to the new hire rules on it. There are some FAQs that relate to auto enrollment and the 90-day waiting period. There appears to possibly be a definition of full-time that's a bit different from what the ACA has. I don't want you to get too drilled down with this. I do think you should have the conversations with your vendors hypothetically. Look, if this goes through, how are we going to handle this, right? How are we going to handle the opt-out? Good conversations to have. The hard details on this have simply not been defined. For example, do you auto-enroll dependents? We don't have that detail. 90-day waiting period, same thing. Would love you all to access 2012-17 so you can take a look at it. It definitely gives you some examples, and it even gives you examples where you possibly could have different classes of employees that have access to different eligibility rules, which is exactly what I'm going to talk about here. This is my last piece. 105H. No one's paid attention to this forever, as Bill and I had a conversation yesterday about this. The reality is, in 2014, they're going to pay attention to fully insured employees. After they get done with that, they're going to turn their head to the self-insured. If the exchanges run well, they are definitely expected to go after the self-insured and give us harder definitions of this. If the exchanges run poorly, they may not. We may just be going on 30 years before they touch base with it, because they don't want to aggravate you so much that you drop coverage. But I will tell you, if you have hourly employees and you're thinking about doing something different over here than you are over here, really important that you think through 105H. You have an advisor that can walk through what you can do legally. There are about three tricks to the trade in terms of how to possibly make all that work. I understand this man's an expert at getting everybody to pass tests, right?
Sometimes.
Yeah, sometimes. But I will tell you, for my large groups, this is a big piece. Nobody's saying nobody's paid attention to it for 25 years. They're actually saying, what is our strategy? Because a lot of groups want to discriminate under 105H. They want to offer something different to one population than they do to the other. Determine what you need to do to stay alive, basically. So with that said, let's go through this. These are my... If you want to ask me some questions, you want me to talk about strategy?
Yep, strategy.
Well, let's talk about strategy. I think we're running past the point of the questions we were going to ask. Let's just turn it back over to you on the strategy side.
I've already said this a couple of times. This is a total business issue. So when you look at, even over here, play, pay, and pay, you are all not going to fit into this bucket. If you have, and I spoke to several employers yesterday on one-on-one sessions. Some of you already have a fantastic plan design. Your eligibility rules are already at 30 hours. People are covered under a 60-day waiting period, maybe a 30-day waiting period. You've got your act together, right? No intention of dropping that health insurance coverage. That's fine. Absolutely. I think it's fantastic. However, let's talk about the PCORI fee. Let's talk about the transitional reinsurance fee. Let's talk about the reporting that you need to do. Let's talk about the fact that you are going to be hit with an excise tax. That's one group. Group in the middle. Maybe your margins are a bit diverse. You've got a mix of high and low wage earners. Still important to you. Maybe you have a few hourly employees. Then you have your low, or your pay. Lots of hourly employees, lower revenue stream here, right? Benefits are not as big of a piece of the value proposition. I will tell you that's a very standard slide. Pay is not the way employers are going, which actually makes me really happy, not from a standpoint of just dropping coverage, but employers are starting to fight back. Again, you don't have to use your total business philosophy by choosing to make changes on your benefit design. I think that we're in a position, I know. How do you control benefit costs when we're covering 85 to 90% of all the claims that come in? And I used this analogy yesterday. We chose to go to a $2,500 deductible plan about 2 years ago. Did we get noise? Absolutely. We went down to one plan design. We got rid of a few options. Went down to one. Who's the person that had the first claim? I did. Or the first injury. It was me. Injured skiing. Thumb was like this big, sticking it in the snow, thinking, well, I can't go to the emergency room because that would be teaching my employees the wrong lesson. So after an hour of pouting, I sucked it up. My thumb was not broken, and it is fine today. So do you have that thought process? Absolutely. Are those knee-jerk reactions? Absolutely. But I think that what we are all in is we are going to be having these conversations anyway. When I define, and the industry, any consultant is going to tell you, peak performer, peak performer, peak performer. That's what you're trying to get to. Peak performer is not having a trend more than 2 to 3% annually. And if you can get it down to zero like Safeway, does anybody know the Safeway model? Safeway is the administration, the Obama administration was in love with the Safeway model when we went into healthcare reform. Safeway started with a CDHP, a consumer-driven health plan. And then they went to a standards-based biometric screening. And standards-based biometric screening means your BMI needs to be at a certain level. Your cholesterol needs to be at a certain level. Your glucose needs to be at a certain level. If you don't hit those standards, you're paying the higher premium. It is a tough decision to make as an employer. And as a consultant, I would walk in every year with my recommendations of a 3 or 4 year plan. You'd be all proud of the document you're about to show, and I would always load it up because I would know that I would only get 1 or 2 of them approved, right? Because here's been the conversation. I don't think we'll get the budget approval on that one, or we don't really want the employee noise. We really like to provide this level of benefit to our employees. Let's look at that next year. We're not in that situation anymore. If you wanted to defer, and this is your primary battle for those of you that already have that beautiful benefit plan that you don't think is going to be impacted, the federal government is expecting you to do nothing. They're expecting you to pay the extra fees for that excise tax very, very soon. They're expecting to get the money off of penalties if you fall out of line, right? So what employers are doing is they're very quickly approving 70% of those peak performer strategies that we used to put in place. This is aggressive, and I'll say this over and over and over again. It's your job not only to be aggressive to protect your company, but it's also your job to be aggressive to protect the health of the employees. When I testified in Washington, I absolutely said to them, it's irrelevant. This whole law is irrelevant in terms of the health of the employees. I'll have employer groups that will have a set of employees that will go to the emergency room 12 to 18 times a year with over $1,000 to $2,000 a hit. What is that about? And what are we doing by almost paying for it? Is that helping their condition? It's not. And again, I know that the knee-jerk reaction on a lot of cases that it is painful to take it away from employees. Somebody yesterday told me that employees bring in the CPT codes and ask them how they pay. How do you pay for it? Before I start working for you, how do you pay the CPT code? I'm not suggesting that you take, if you have a budget of this for your employees, I'm not expecting that you do this. I'm stating perhaps you do this over here and you reinvest somewhere else. That is what employers are looking at today. And probably the last slide I'll be able to and it's so hard for you to probably read on this. Here's your emerging trends. Financial management. What is that? Audits, right? Big trend right now. Dependent audits. Nobody likes them. But I will tell you, some of the largest employers in the nation, in the world for that matter, are doing these audits. Medical claim audits, PBM audits. Do you know what the spread pricing is, and does it apply? Because that's a big deal. And if your consultant or advisor is not talking to you about it, ask them. Because it's time for you to cut out that fluff. It's a good time to go to market on certain products, life and disability, soft. Cut out the cost there. If you're going to be bringing in more employees and you want to have more money to put it in other pockets or verticals of your business strategy or your employee HR strategy, cut costs somewhere else that you don't need to have this fluff built in. Provider connectivity. Look, this is just instituting some basic principles of cost containment within your plan. And maybe it is some of the painful items, such as we talk about pharmacy. Get a little bit more aggressive, okay? It's not going to kill people to try to save money on. He showed me an article yesterday, which it is a big trend right now to say, here, try the $450 drug, and we'll cover your copay on it. It's okay to get aggressive. It's okay to talk about the tri-generic programs and the Retail 90 and the mail order. It's okay. You're not going to be the only one that's doing it, I can assure you. Network. Getting networks of excellence. Talking about community-based programs. You'd have high ER claims in a particular area. Get involved at the community level. Technology. Goes without saying, there's a lot of pieces that we could bring into the play on this one, but you better know your reports, right? You better know your eligibility. You better have the detail on your employees. Financial incentives. We're talking about compliance. If you have the diabetic that's complying with the rules for having diabetes, maybe you're incenting them to have that, getting the insulin on a timely basis. I see a lot of that. Maybe you're giving incentives into an HRA if they meet certain standards of the wellness program. Maybe you're doing a HIPAA premium differential if they meet standards, and the standards I laid out. There's no cookie-cutter approach. If you're going to do biometric screening, look at your claim designs, or your claims and your plan designs. Figure out what the trends are. Get aggressive with it. Again, it's time for these people to get healthy. Account-based health plans, everybody's doing it. Everybody. J.P. Morgan Chase ripped the Band-Aid off and put in a CDHP. It's white collar, it's blue collar. Look, employees constantly squawk about the fact that we have higher premiums. It's okay to offer them something that's lower. You need to communicate. You need to communicate in a kindergarten fashion. A reasonable expectation on enrollment for a CDHP rollout first year is about 5%. I have cases that get up to 25%. You have to educate them. If they are educated, you will have a lot of employees that just go, look, I'll take it. I want the cheaper out-of-pocket cost. This makes sense to me. Employees, and they will re-enroll. It's not as scary as we think. Allow them to have the choice. Protect yourselves. So I have gone over my time. I don't know if you really want to open up this to questions.
Actually, your last points are probably the best way to transition to the second panel. But if Robin didn't scare you a little bit, then we haven't done our job here. We actually got an email from a client, and I'm not going to throw them under the bus, but the email was, hey, I was signed up for the seminar. We got this yesterday for tomorrow. But I went and talked to my boss, and the boss said there wasn't enough information about the health care reform, so we're going to wait to do anything until we get more information. That's a strategy. It's not one that I would recommend, but that's a strategy. As you could see, listening to Robin, and you'll hear some more in the next two panels, proactive. You just have. I know you're getting tired of the game changer and all these other things, but if you sit still, you're going to get burned. Bottom line. You have to be proactive. And the last thing, before our break, you can see why it's imperative to have a team. You've got to get your consultants and your lawyers and your HR and the CFOs and the boards and everybody. This impacts every single company. And you've got to make sure that you're not alone trying to go through this maze. And you can see what's out there, what options are available. And as confusing as it is today, it's not going to be any better tomorrow because we were laughing. You get a notice and it clears up one question and it raises 10 more. So you've got to be out there. You've got to be engaged. I appreciate you coming to the first session here. We're going to take a 10-minute break. We'll be back at 5 till, and we'll start our second panel. Thank you.